So as Linda said, she and I together have been at this for a really long time. The very beginning, we had cardiac imaging, and we did cardiac MRIs because we thought maybe we could see some more stuff, but better than echo. And we did the study where we pulled all the EKGs by hand and looked at all the EKGs and determined that the EKGs were abnormal. And then we started with meds because we thought we should. And gene therapy was on Star Trek. I mean, nobody was going to do gene therapy back in 2005. And all the cardiologists had data, which was great, but it was in those little silos that were talked about earlier. And everybody had their own little Excel sheet, and everybody had their own little database, and people sort of talked to each other, but not a whole lot. And so there wasn't a lot of aggregation of data, and there wasn't a lot of working together, which meant that everybody still continued to do things a little bit differently, which wasn't in the best interest of the patients. So we're happy to say that Chet's going to talk about the Action Network, which has been incredibly effective in aggregating data and starting to get people to talk, starting to get people to harmonize in their practices and medications and therapies. So he's going to tell us a little bit about that network and how it's going to continue to be effective.
So thanks, Kathy. And I think to start with, I think saying thanks to Kathy and Linda. I think they were integral to a lot of what I'm going to talk about today, but also to say that I wouldn't have gone into this, I think, without what they built in Cincinnati from a cardiac perspective. So Linda, thank you, because I think none of that would have existed. And I didn't, when I started cardiology, I did not think this is where I was going to be by any stretch of the imagination. And a lot of what she built kind of brought people in. And I think that's what we're trying to mimic on a more national scale with Action. There you see my disclosures. And so to kind of give you a little bit of a layout, so first I'm going to talk a little bit about what Action is, because it's relatively new to the game here. So some of you may know what it is. Some of you may have heard a little bit, but I'll talk some about kind of where that started, where there's some common themes for dystrophinopathy care, because that's not where it started. It started in ventricular assist device care. And then we'll kind of go from there. It has a very broad portfolio. I'm going to try and focus on some of the things that I think really apply nicely to what we want to do right now from a dystrophinopathy perspective. But there are a lot of potential avenues to go down in the future. And so one of the things I'm going to focus on is how we started from an Action perspective and from a device perspective in interaction with the FDA and getting the voice heard there. I'll talk some about the initial CDCC grant and then touch a little bit on the cardiac care meeting that you heard a little bit about for where we're going to try and go in the future. And so Action was actually started in 2017 with a focus on heart failure of all causes in pediatrics and young adults. And as you can see here on this graph, we started with a really small group. We weren't sure who was going to buy in, who was going to try and do any of this. So we started with 5 centers, and we said, hey, if we get to 10, that will be awesome. And now, a couple of years out there, now 58 centers from around the world collaborating to try and figure this out. The other important part about this is it's not just clinicians. It's actually bringing all of the stakeholders together. So that's patients, that's family, that's regulatory, that's industry. Because we know with rare diseases, if everyone's doing their own thing, our voice won't be heard, right? Linda, as you heard, has been trying to do this for 20 years. And sometimes I'm sure it felt like you were just kind of screaming into a black hole. As we build a group together and as we go forward and say, here's what we think matters, the patient voice, the clinician voice, all of that, and then build the data on top of it, we tend to get somewhere much faster. And so how we got here. So as it turns out, what you've already heard here and what you guys know is cardiac therapies aren't studied and aren't funded for children and young adults, full stop. There are studies with literally thousands of people who are in their 50s and 60s, and there are multiple studies. There is less than 1% of the heart failure budget that comes from the NIH goes to children and young adults. They like to put us up on billboards and they say, here, fund this. Look, here's a cute kid who has heart disease. But then they don't actually give any money to actually figure that out and to move things forward. We need to change that paradigm. And the reason that matters is without that funding, without understanding that natural history, we have no standard of care, right? You guys live this every single day. You know, if you come to some of our centers, we're tending to kind of come together about what constitutes good care. If you live in New Mexico, if you live in Kentucky, if you live in North Dakota, the standard of care is really nothing. There is no standard of care because there is no data. And so from an action perspective, where we started was in heart pumps in small kids for the most part. And the reason why we started there is because we knew we had the most opportunity for learning and improving care. So this is one of the patients that I've taken care of. And she has that little pump that you see outside of her, which is a little ventricular assist device. It's the only ones that we can put into very small kids. And why this matters, what was the burning fire? Why focus on that group? Well, it turns out with that pump, which is different than the ones that we use in Duchenne and Becker's, but with that pump in particular, 30% of kids who were on that pump had a stroke. That is devastating. We had room for improvement. And so we got multiple people together and we said, hey, it turns out nobody is really good at this. Some places are a little bit better than others, but everyone needs these. Whether you're in Cincinnati, whether you're in Texas, whether you're in California, whether you're in Oregon, everybody uses them, some more than others. But the numbers are very small at each institution. Even the biggest centers, our numbers are small. And so to be able to try and understand what is effective and what works takes 10 years. So after 10 years, we can tell you, here's what probably works well. That's not good enough, right? Everyone, there are boys and young men who are sitting here waiting to understand what is going on right now, and that's not good enough. We can't wait 10 years, 20 years to answer that question. And so to be able to answer that and to affect change in a timely way, we need to swim together. We need to understand outcomes, we need to optimize care, and we need to amplify our voices. And the good part about all of this is as you start to look at it, it turns out all of those things actually come together. How we're going to move forward with understanding cardiac outcomes is actually how we're going to move forward with the FDA, and it's how we're going to affect care right now. So they all kind of come together. Don't think of them as separate. It's all one thing, and they're all generally trying to move together in the same direction, and that's why you have the School of Fish. And so as you heard from a harmonizing perspective, where we started was those small heart pumps. And it turns out that was a big deal because guess what happens when you try and put 30 cardiologists in a room and tell them to do something? It does not go very well. But we started with the most severe in part because we said, hey, nobody is good at this. And we all kind of acknowledge that. If you have some people who think they are tremendously better, you're never going to change their mind, right? They're going to think, oh, well, I'm the best at this and everyone else can do whatever they want. We acknowledge that we all needed to improve, and here's how we're going to move forward. So we started to standardize care. So we agreed to change to a specific kind of blood thinner, and we came up with this harmonization document. We say it's not a protocol because we can't really force people to do it, but if you're going to do it, here's what the people who are the best at it say, here's how we should go about doing it. And because we have no data, why not just follow this? Because you don't have anything else to go off of. Why not just come together and let's start with this, because then we can work from there for how to improve it. And this from the CEO of that company that said basically overnight, we did what he had been trying to do for years, which is trying to pull together and standardize how we're doing this. And it turns out once we started that, what we found is people loved it. And in fact, they said, well, I don't want it just for that. What about how we clean these pumps, how we monitor them, how we treat infections? What happens if someone has to go to the operating room? Because what happens right now is if somebody's trying to do that, they just call somebody in Cincinnati or at Nationwide or at Stanford and say, how do you guys do this? And we can make this more efficient. So we set up this learning management system, which now includes too many protocols to count. So this is just a short version of that. And we basically brought people together and say, okay, each one of you has a protocol. Let's look at all those protocols. Let's find the commonality, and then let's agree on what we think is the best approach to move forward. And if you want to look back at the other protocols, here they are for you so that you can decide what you want to do. So it really was putting together kind of an information storehouse or warehouse. And why this matters is now you're starting to get a group that's collaborating and that is working together, and you have multiple of them and their patients at each place. And that really matters because now when you start talking to industry, when you start talking to the FDA, your voice is much stronger. And you're in a place where you can actually deliver some of the things that we haven't been able to do before. So we asked ourselves, how do we as clinicians assist industry and regulatory bodies? And that's assist, not dictate, so that we can start to get pediatric studies and so that we can assist on labeling that already, for therapies that already exist. And can we use real world data to do that? Because trying to get these clinical trials is a challenge. And it's especially so when you think about in Duchenne where you have competing trials. And so imagine if you have 20 different trials going on at one time, you're not going to be able to get the answers that you want. So we need to be able to try and include real world data in from that perspective. So we got ourselves at the table, and ultimately we had some initial successes, one of which was the HeartMate 3, which is the pump that we use in Becker and Duchenne right now. And we were able to move forward and get labeling based on real world data for that. And why that matters is that also, right, industry for a long time, especially in pediatric cardiology, was a bad word, right? Because a lot of what we saw is they would not fund research from a pediatric perspective, and they weren't providing educational material. And from a VAD perspective, that was especially the case. Any of the documents or pamphlets that you looked for a ventricular assist device had a 60-year-old man fishing on a dock. And so a 15-year-old's gonna look at that and go, I'm sorry, you wanna do what? That wasn't working, but they wanted to. The problem is their indications and their labeling from the FDA didn't allow them to. So if they were seen as promoting that device in a group that it wasn't studied in and they had no data on, they really were going to be potentially in trouble. And allowing to go down this route allowed them to kind of help us from a funding perspective. We had the expertise to be able to go after it and write it, and to write it in a way that's appropriate for teenagers and young adults, not for a 65-year-old man in a fishing jacket. And so how does that kind of come back to from dystrophinopathy care? I think this is another thing that matters, and I think that Linda alluded to earlier, is at this very meeting a couple of years ago in San Diego, as Action was starting to take off, we said, oh my God, there's so many commonalities here. Can we use this regulatory framework? Can we use this group to apply it to dystrophinopathy, right? Because you have a rare disease. There's no standardization, as you've heard over and over again. PPMD has been trying for a very long time to kind of move people in the direction of standardization, but it still remains a challenge. There are individual sites of excellence, right, from many of the people that you see up here, but it turns out if you're not within a couple of hours of Cincinnati, getting there is a challenge, and especially as more and more boys become men and get older, it's still a challenge, even for people who want to come see us. At any of our centers, it's becoming a challenge. We have to find ways for outreach and standardization as people get to a place where they have to be more at home or they can't get to us. And lastly, the educational resources. We're in a desert right now. It's an educational desert. When you get to men who are asking what this means, what their life means, what I always tell them in clinic is, well, you're writing the book right now. Well, that's not good enough, right? A teenager and a young adult does not accept that answer, right? They want to know right now what's going on, what are you trying to do, and right now we give you, well, we don't know right now, we're going to figure that out, and they yell at me for that. And so from a cardiac care perspective, what's that burning issue? Here it is, right? There is good data now out of Europe in multiple places. Cardiac is the leading cause of death in DMD, full stop, right? How many active clinical trials are there in cardiac disease right now in Duchenne? If you go to clinicaltrials.gov, there's one currently enrolling. And as you heard from Linda and from Tim, we're not even paying attention from a cardiac perspective for those trials that are going on from a skeletal muscle perspective. Or what we're doing is looking at safety. In a patient population that you just heard from John is one where we see cardiac disease maybe in about 10%. We have no idea what this means over the long term. This is where we need to work together with industry, because they do care. They just can't do a 15-year study. No one can do a 15-year study. You can't even get a clinician to stay at one institution for 15 years, right? We have to work together to be able to try and answer some of these questions. And then potentially we can also go back to the FDA for additional labeling and other stuff for things that do have an impact on cardiac disease. And then that last part, this is one that breaks my heart, right? So from a heart failure perspective, so I do neuromuscular disease, but I'm also a heart failure and transplant doctor. And so we put those and manage people who need a ventricular assist devices. 3 of the people who came to our center didn't come because their cardiologist referred them. They came because of connection through PPMD and through people who were implanted. They were even told to go home and that no options existed. Now, VADs aren't right from everyone, as you heard from Linda. We've actually told more people than we've accepted that VAD, we don't think this is the right choice, right? And here's why. But to never be presented that as an option, that gets me fired up. And so from a CDCC perspective, where we started with this from an action perspective, we really had 3 big aims. One, we wanted to understand the landscape, not just at 5 or 6 centers, but more broadly within action about how people were going about doing things. 2, we wanted to get a little more scope on what we were doing right or wrong from an information and from an overall perspective for patients and families, and especially for young adults, because I think we're only starting to understand that voice as more boys are becoming men and finding their voice themselves. And then we wanted to start prospectively enrolling that database. So from understanding the landscape perspective, we've had our first publication looking at how a practice varies from center to center, and that's not really a surprise. And then 2, we're looking at VAD outcomes right now, and that paper is under review, and hopefully we'll be presenting that more granular data next year. And so I'll actually work backwards from that because I think the patient voice is probably the more important one for now. But we're actively enrolling for patients who've had an LVEF of 45% or less. So we have over 100 patients at this point. But this is the hearing your voices, right? This is what are we doing right? How can we get information, and what are the things that are driving you? And I think the first part that we realized is, as I said, that information desert, right? And I refer to this as the mom book, right? So when someone comes to see me in clinic, 1, it's not just me. There are, you're there for 5 or 6 hours, sometimes longer. And we are inundating you with information. So what one of the boys said is, what you say makes a lot of sense in clinic, right? I got you. I'm with you. Here's what we're doing. You ask me 2 weeks later, I have no idea what you talked about because we just got filled with data. And so moms come, right? Again, and for you dads who write too, great. But I say it's the mom book because that's most of the time who's writing. That's why you write it all down. You're trying to keep track of all that information. The problem is the adult men don't have that book. They want access to it. They want to understand a little bit better. They see this information desert, both in terms of their own care and for what's going on from a natural history perspective. And they said, we need you guys to do better. We're not good enough. As I said, the natural history you've heard multiple times, they want better answers. Writing the book right now is not a good enough answer for them. And then they hear these murmurings about a VAD or an ICD, and they actually didn't know what any of that meant. And does everyone get one? Am I going to get one? Am I close to getting one? What is heart failure? All of those sorts of things. Those are things that we probably aren't talking about, or based on the conversations I have, we aren't talking about early enough. So they just see this and they worry about it. They don't know what's coming down the pike. The other thing is how do they want that information? It turns out Burger King style is what they said, right? Some people want it on their phone, some people wanted a PDF, some people wanted emailed, some people wanted on the internet. And then one of my favorites from one of the teenage boys, he said, that's all well and good, but my parents can't even use their phone. They're gonna need it in paper. And so we have to find a way to make this accessible, both for people who are, say, coming to Cincinnati, or again, I'm gonna use New Mexico, right, as an example, right? They need to be able to have access to this information, even if they're not able to make it to other centers, so that we can distribute to families and to patients what the best care is. And so here you see our initial draft of what we're working on for talking about some of these medications, right? We're getting up here, we're going through some of them But again, you're going to spend the next couple of days here learning about all of these things, and then you're going to go home and go, wait a second, dear God, I heard a whole bunch of cardiologists talk about it. I heard things about gene therapy, and even for somebody who, studied all of this, I didn't finish till I was 33, and then Tim's up here talking about stuff. I was like, that didn't even exist when I was in medical school, and you're going to try and keep track of that? That's impossible. Right? Each of us is up here and we spend all day trying to learn stuff. We need to have an information warehouse, just like we're doing for the clinicians and other stuff, to get you guys access to data, even if it's an introduction for where things are going. And then here's one of those moments where you just have to laugh. So one of the late 20-year-old boys said, this really drove it home for me. He said, whatever you do, make sure you don't go to Wikipedia. It'll ruin a date really fast. He was trying to find a way to explain Duchenne to a date. And they went on Wikipedia, and anyway. So the cardiac care consensus meeting. So where are we going to go from here? So the first thing is we brought together multiple stakeholders, again, like Action has done. We tried to take some of what we were learning on the patient voice and developing a roadmap for collaboration. And I think this is, again, really important. How you get cardiologists from places all over the country, each doing their own thing, to try and standardize some of what we're doing so that we can all move in one direction and have a voice that's heard in a better way. And as I said earlier, the barriers to care are the barriers to clinical trials, right? Cardiac natural history is lacking. I can disagree vehemently with the FDA trying to apply things that they're doing for heart attacks to Duchenne, but the only way we're going to make that point made and to change that is by actually showing them the data. So we need to understand that. And how do we do that? One, by harmonizing care. So this matters for getting you effective care right now, but also making sure that natural history data is understandable, as you heard from John, right? So if everyone's getting an echo in one part of the country, but MRI in others, it's apples to oranges, and the FDA is going to say that. And if we're trying to create a clinical trial to see if something's effective from a cardiac perspective, we have to be able to compare apples to apples. And it turns out if everyone's on 9 different medications and you're trying to figure out if one new study medication makes a difference, it's going to be very hard to do that because you don't know if it's those other 8 medications that makes the difference. So if you're on similar medications, it helps in trying to develop those clinical trials and getting you guys the data that you need to give you effective therapies. And then there's the whole question, right? All of this is based on structure of the heart. What does this mean for how people feel? Right? Because that's where the rubber hits the road. I don't care if I can make your MRI look better if you feel like crap, right? We need to have a way to understand what heart failure looks like, what symptoms look like, and do these therapies improve that? Because that's what you want, right? If your MRI looks better but you don't feel good, it's not an effective therapy. And then what about Bmd and carriers, right? We're starting to learn more and more. Can we apply the same therapies? Are they different? Can we enroll all dystrophinopathies into things? How can we go about doing that? And it turns out while we have no significant, or we need better natural history from a Duchenne perspective, there's next to nothing from a BMD and from a carrier perspective. So how are we trying to go about doing that? One, first, we're trying to understand for all dystrophinopathy, we're going to kind of broaden that initial group that we talked about from an Action perspective. It's no longer just going to be people who have an LVEF of 45% or less. We need to understand the full natural history, the earliest stages of disease as well as the later stages. We also need real-time analysis of the cardiac phenotype of each of those therapies, as you heard in my rant earlier, right? All of these things from a skeletal muscle or from a pulmonary perspective, we need to understand what the impact is from a cardiac perspective. And then, too, John, it's perfect that he's up here. Smaller groups are trying to work through how we can compile cardiac MRI, again, making sure we're all getting the same sort of thing so that we can provide some of the granular answers that the FDA and or industry needs. I'll skip through some of this, but basically saying, hey, we're trying to harmonize our medical therapies. You already heard John talk about it from an MRI perspective, and Andreas is going to be giving us input on ambulatory electrical monitoring. So this is the initial draft of that. And so I think also showing that we can work together and bring in other subspecialties within cardiology to try and inform some of that decisions. And then from an action perspective, we also have an app that already exists and is already doing studies from a VAD perspective on patient-reported outcomes. This is something we need to do from a Duchenne specific one. And we need to make sure that we make it a little bit easier to assess some of these, because as most of the people in the room have filled out, when you get that 50-question questionnaire, dear God, it is awful. From a VAD perspective, we were only getting that filled out about 30% of the time. So we couldn't even use that as an outcome of interest with the FDA, because they said, no, you're not getting enough data. There are huge gaps in this, so we have to find a way that we can collect that data. It might be through iPads, or through phones, through that sort of stuff. We need to use the newer technology to be able to understand how we can do that. Anyway, so these are some of this is mock-ups that I'll skip for how to do that. So really, I think one is a thank you to PPMD for the support that they've provided, and also to bring us all together, which I think is the second part about it. It's not just support; it's bringing people together to try and answer the questions that we're trying to answer. And I think this quote says it well, right? Vision without action is a dream, and action without vision is a nightmare, right? We need a little bit of both. And I think that's where having a central group of people that's kind of leading the charge is going to be important. So I think, again, thank you to PPMD, to Pat, and everybody else. Dear God, I think you guys have gotten a lot of emails over the last couple of weeks from me, so thank you also for returning my emails, and to the Action Collaborators. So as I said earlier, Linda has been integral to me choosing to do this, but also in being able to move forward from an action perspective. And Deep, who is her co-cardiologist there, unfortunately couldn't be here this week. And then also to Nikita D'Souza, who's the administrative lead for Action, because again, having to deal with me and wrangle all of the cats is more than a full-time job. We have a variety of collaborators that I won't talk about, so thank you.
Thanks, Chet. I'm really glad we saved you for after the break. I would hate if you'd had to rush through that. So we have questions, and this is the question and answer part of the program. So there's a microphone there. If you have a question, please go to the mic, and we'd love to entertain your question. So I'll try to run through some of these. So John, just to start, is there the gadolinium controversy? Is there a danger with gadolinium? I know that comes up with you in clinic and has come up with the audience.
Yeah, that's a great question. So there are two things that we worry about. One is something called NSF, which is nephrogenic sclerosing fibrosis, and that is something that was described with our older contrast agents in patients with renal disease. And so for a long time, we've used a cutoff of 30 for a GFR, which is a way to calculate renal disease. We've never seen it with our newer contrast agents that we use, that they're called multicyclics. And it's gotten to the point where some adult cardiologists have said that they don't care, and so they're giving those contrast agents to adult patients even with GFRs less than 30. We haven't done that in pediatrics. We're very conservative. We don't like exposing people to anything that could cause harm. The other thing that with gadolinium is deposition of gadolinium in the brain. And that was found, I guess, almost accidentally, and it goes back kind of in the back area of the brainstem. We don't really know what that does. It's never been really linked to anything. We can see it on MRI when we do brain imaging, but we don't know what to do with that. And so there was a black box warning by the FDA, and a lot of us, Cincinnati, Vanderbilt, a lot of our centers had already been limiting GAD whenever we could, and so we still do that. If you talk to a lot of the MRI people, more recently, people don't think that GAD deposition is a big deal, and it also is much less likely to happen with the multicyclics, the newer gadolinium contrast agents we use. But it's still something we're very cognizant of, and so we try not to expose our patients to it. And we're still trying to figure out if there's any long-term issues with it. I can tell you we did a study where we looked at patients who'd had brain imaging and it had multiple administrations of GAD, usually an older kind of GAD, and didn't see any difference in those who had gadolinium contrast and those who hadn't in their brain MRIs. And some of them had 5 or 6 administrations of gadolinium. And so we weren't able to see that brain deposition. And other groups that we've worked with have done similar studies in pediatrics looking retrospectively. So it's a very long answer to say that we are very cautious with our administration of gadolinium. We think the newer agents are safer, and we never want to put anybody at risk of getting GAD. And so we do definitely limit in our Duchenne patients. So the older ones that have a lot of scar already, we tend not to give them gadolinium or only give them every couple of years.
Okay. So along that line, if you've already identified a scar in an older patient and that scar seems to have reached its scar burden, is there a reason to continue to do MRIs in an older patient, or can you switch to echo, or what would be your...
Yeah, for us, so I have a couple patients where I do an MRI every year, and I've just said, look, so we do every 1 to 2 years routinely at Vanderbilt, but we're not like every year and everybody. But there are some patients where I just can't see their heart on echo well enough. I just can't. And so I do a non-contrast MRI. We can do that in about 20 minutes, 15 to 20, depending on the patient. And I do it to look at their function, because when I do an echo, I'm kind of like reading tea leaves. I can't tell what's going on with the heart. And so that's why we continue to do MRIs. But you're right. I mean, so in those patients, those are the ones that we don't usually give them contrast anymore.
Okay. Anybody else want to?
Well, and I think to go to John's point, if you're going to get a study, it's got to be useful. If you can't see the heart, my answer is, why are you even subjecting somebody to an echo? And so we take a similar approach, which is we try and minimize gadolinium where we can, but there is a lot of value in terms of understanding what that is over time. And here's the other part where that learning together makes a difference, right? So at each of our centers, we are used to doing MRIs, right? Thousands of MRIs have been done, and we can do it quickly. So when someone says, well, no, I take care of Duchenne patients and they can't get on the scanner, no. So there are some who can't, but I think that's used as an excuse too much because it slows down the MRI suite and the radiology, and I'm serious, right? It takes time to be able to do it, especially if you're not used to doing it, but if you're at a center that can do it and has the system down, you can still move forward, and I think it does have important information. It's not to say everyone gets it, but I think sometimes we use that as an excuse, and really it's in part because radiology needs to get their scans and they're worried more about time than about the patient, to be blunt.
I mean, this is a disease that requires imaging. I can't make good clinical decisions about how to manage your care without seeing what's inside your heart. And MRI offers the best way for me to see what's inside your heart. So that, I think, is the test of choice in this disease. Now, with all the modifications of statements that have been made so far, you know, I mean, patients who can't get in the scanner, other reasons why we need to use echo. But the optimal imaging modality at this time in 2022 is cardiac MRI for Duchenne muscular dystrophy.
And it goes to actually Linda's point, which is, right, so it matters less if you can assess symptoms and other stuff when your function's down, right? So for my other patients, I can ask them, how do you go up a flight of steps? How do you feel? Shortness of breath, all that other stuff. Trying to assess that in somebody who is non-ambulatory, has some degree of respiratory disease on top of that, is actually a huge challenge. This is why we need to be able to use that. And while we're working on trying to get those biomarkers better, as you heard from John, it's still not quite ready for prime time. We're making sense of that data. So right now, the best thing that we have is imaging, and it helps us make sense of things when it's otherwise pretty confusing, even for people who do it a lot.
So it's the most appropriate test for patients for whom it's the most appropriate test, right? So for patients who had difficulty being in the scanner, sedation, do you recommend sedation? And does sedation alter the MRI? Are there concerns about that?
So for us, we don't use a lot of sedation with our MRIs. We will use a little bit of Valium sometimes, but it's always in consultation with our pulmonologist, given the respiratory issues with Duchenne. So we don't want to tire or put someone to sleep and have them not breathe enough. And we don't want to put them to sleep either. I mean, so with a cardiac MRI, you need people to be awake and lying still and holding their breath most of the time. And so it's really just for the anxiety part that we'll work on it. And we've had some success with some Valium. We don't use deep sedation or anesthesia in patients with Duchenne because of the respiratory disease. So it's just like very mild anxiolytic stuff. We do that in a lot of other cardiac diseases, but in our mind, at least, it's not worth the extra risks.
Same.
Same.
Yep. Same with us.
Same. And I've also heard that some people don't do Valium the way they should do Valium. Sometimes it goes the other way and they just crawl right out the other end of the scanner, and that's
definitely
true. Always fun to chase. So talking about medications, many of the boys
Kathy,
are.
do you have a question?
Oh, I'm sorry. Sorry.
Okay, so I think now I might have 3 questions. First, what about for a young child who is not able to follow directions well in an MRI? And if they were to sedate, does that negate the outcome? You know, is it still going to be a valid outcome? So that's first. And then second, I'm wondering if there's any, you had talked about kind of the moms and those with cardiac issues and that sort of a thing. And I'm wondering from the study that was done for carriers, if there's any way to get some data from there and potentially do some work, you know, with the moms that are in heart failure. And my daughter's one of them, so I'm passionate about that. And then we'll start with those 2. I can't remember the other.
So a lot of these kids are on the autism spectrum, and they don't follow directions well, right? So how do you manage those guys?
So for now, at least in our center,
Duct tape. No, just joking.
So for now, we really try to coach them through it. We have child life, and we do the best that we can. We have better and better sequences that don't require breath holding, and we are learning to sort of improve those. But I would say they're still not quite where we want them. But we can use that, and we can usually we do 8-year-olds pretty easily. Our techs hate us when we put them in the scanner because they don't often hold their breath, but they also breathe pretty regularly, and so some of those sequences that are newer actually work a little better on them, and we still get information. In terms of your question about sedation or anesthesia, that's a great question. So a lot of the medicines we use to put a patient to sleep will have some, or can have lead to some cardiac depression, and so we will sometimes see lower function that we then attribute to them being under anesthesia. And so I think that's another reason that we don't usually sedate or deeply sedate our Duchenne patients. But we do that a lot in other patients, and we end up going, well, the function's not normal, but he was under anesthesia, maybe that was the reason. And so that can affect it.
Does that answer your question, Susan?
You know, I can answer the cardiac question for maternal carriers. I mean, I think that is a huge black box that must be addressed in the coming years. You know, the Parent Project Muscular Dystrophy sponsored a grant with Mei Ling Ma, who published the data, who found that 50% of the moms that we scanned had some degree of myocardial fibrosis on cardiac MRI imaging, which is really impressive. How young, we haven't pushed the margin in how young to look. And I have definitely had anecdotal reports of teenagers who are female carriers, who are unaffected from a skeletal muscle standpoint, who do have fibrosis on cardiac MRI imaging. The thing that always sends the message home to me is, unfortunately, if the child or the young man passes, that family tends to be lost to this community, and that information is lost to us. So are mothers or maternal carriers of Duchenne passing away at earlier ages themselves? For example, if you have a 65-year-old woman who passes away from heart failure, you don't think too much of it, right, as opposed to a 22-year-old female. So So I think the urgency to finding some of these answers is out there, and I think we really need to work together as a community and maybe even tie it into action as we move those things along. Because I do think we need to go back and try to collect this data. Now I say that because I think this community is critical to doing that. I think that the only way we're going to collect this data is through collecting it from you guys. Aunts, uncles, grandmothers. My grandmother, passed away at age 45 of heart failure. Could that have really been Duchenne, not the myocardial infarction they think that she had? And so I think that we're going to need to tap into that.
So I'm just going to comment one thing real quick, because when we very first started this journey, that was one of the things that was mentioned in one of these conferences was finding out more about carrier moms and them, and for lack of being the guinea pig for their sons, honestly, in some of the things that we need care for because of the issues with getting approval from the, to do children's studies and that sort of a thing. And I think for every mom here, and I can't stress this enough, if it were made, accessible to them, they would do anything to help their child, and if that means they do some testing to be able to further knowledge, because they do have the same cardiomyopathy because of the same mutation, et cetera, I just would encourage you to please consider this.
Oh, yeah, no, and I get it. I totally understand what you're saying, and I think it's a really important comment, and I think it's acknowledged. I think that the problem, though, is that the disease process is a lot slower and a lot less evident in the maternal carriers and the moms. And so for the very reason it's difficult to do these cardiac informative trials in the very young children, the 2 and 3 and 4-year-olds, I think it really slows us down in some regards with regards to doing these trials in the moms. I think we need to know what is going on in the moms. We need to treat the moms. We need to think about the moms, absolutely. But to do informative clinical trials, it may not be the best patient population.
So I can only stress that it's very important to look after moms too when it comes to heart disease. And ideally, moms should see a cardiologist within the same center that their boys are at. Now, the problem is that the boys are taken care of by pediatric cardiologists, and they often do not see adult patients. So I'm an adult cardiologist. I see adult younger boys and younger men and men with Duchenne. And I frequently also see moms. And they often, as Dr. Cripe mentioned, have evidence of fibrosis on their cardiac MRI. But, if you're a carrier and you go to an outside cardiologist who may not know much about being a carrier, what Duchenne really entails, they will not do a cardiac MRI. They do an echo. The echo looks great. You're done. All is good. You don't need to worry. And that's unfortunately not the case. We know that there are subtle signs of disease and that can progress as they get older. So I put a lot of emphasis on managing cardiovascular risk factors when it comes to hypertension, alcohol, obesity, diabetes. All that really matters, and putting really emphasis on, essentially the same ways boys are treated with ACE inhibitors from an early age. If I see that there's scar tissue, I know that ACE inhibitors, potentially also MRA, so eplerenone, spironolactone, are helpful. That would be a consideration. So I think seeing that under the same umbrella and under the same roof makes a lot of sense to me.
Yeah, no, I think I'm going to reemphasize that. I cannot tell you how many times I've asked in clinic, as a mom, have you seen a cardiologist? And some of them will say, oh yeah, I saw my cardiologist in XYZ, wherever. And they just said I was fine and didn't need to come back. They didn't even do an echo, right? So I think this is a rare disease, and not every care provider can understand this disease. So I think as a maternal carrier, you need to go to a cardiologist, an adult cardiologist such as Andreas, who understands this disease. And if you haven't done that, you're probably not doing due diligence for your own cardiac care.
And there is a lot. I think about one woman who's a carrier. She has a little bit of fibrosis, but is structurally really otherwise healthy and strong heart. Now, she has profound dyspnea on exertion, so meaning she's very short of breath when she walks minimal distances. And what we found in her case is that she has profound diaphragmatic weakness. So the breathing muscle, the diaphragm, is actually very, very weak, and her pulmonary function test is very abnormal. So you have to think about that too in women, that it's not necessarily only the heart that can lead to shortness of breath, but oh yeah, it can affect the skeletal muscle too, and it can be disproportionate. It may not be the heart, but it may be the diaphragmatic muscle weakness or other muscle weakness in general.
So because PPMD has always been really passionate about finding out about females with dystrophinopathy and caring for women, we've funded a center at the University of Pennsylvania to provide comprehensive care to female carriers with Duchenne, and that would include neuromuscular, cardiac, physical therapy, pulmonary, and psychosocial as well. So if you need any more information on that, we're happy to give that to you. But yeah, it's incredibly important. So thanks for that.
And I think a couple more things. So one, just like with the boys, clinical care and science need to move together. They're not opposed, right? They move together. To be able to provide effective care, you need to understand it. And so you need to move forward from that perspective. The other thing that is really important is Susie, who was on one of those slides and many people knew here, was our biggest advocate from a VAD perspective, right? Because she went to an adult center that wasn't used to doing it, and they saw a woman in a wheelchair and wouldn't provide her with advanced therapies because they saw the wheelchair. And so I think going to a center that is used to dealing with it and can talk about it, I think is extraordinarily important. Sometimes that answer that you get there at home, that no for advanced therapies or other things, is going to be the one that you're going to get even if you go to the best centers. But you need to know where are the centers that will give you a more comprehensive approach and may give you a different answer. Because again, I will say 3 of the people who we put VADs in were told they had no other options, and one of whom is now 4 years out from a VAD. And he's been admitted to the hospital once. So I think you gotta, this community is very good at looking for answers, but you gotta know where to go.
Mindy?
I just have 2 comments. One, are we doing any work around cardiac imaging is the best test. So how do we get these older boys that have contractures in the tube? It's not about anxiety, it's about contractures and making them comfortable. How can we address that?
That's a great question. There are patients that do not fit in our scanner because of contractures, some of the older patients. And so that's why we're putting together our protocol for echo contrast, just because we can't get them in. We have larger bore magnets. We have one at Vanderbilt, and we have another one we're buying that we can use for cardiac MRI, and those will be helpful, but they're not infinite sized. So it's like 55 centimeters to 70.
It's probably somewhat unique that you have the heart failure and the contracture, so it's not like something that's going to be used in mass in a general clinic setting.
Oh no, I'm in the South, so we need large bore magnets because of obesity. We have tons of patients who can't fit in our scanner, believe me.
But not because of contractures.
Not because of contractures, though, no. So we need the larger bore magnets anyway. There are open magnets, but the image quality is not as good, and there are a lot of people doing research on these sort of open magnets that are lower field strength, and that may be a way we can go down the road. But we're working on that, and it is a need for sure.
I thought the slide about you can have a reasonable LVEF but still have a lot of fibrosis, that to me was transformative in the way I'm thinking about cardiac failure. Are we really looking at 2 different things? And do we have an idea about the percentage of boys that might die from a sudden rhythm disruption because of scar versus kids that just, or female carriers like me, that just get into such a state of heart failure that they die from that? So what is the leading cause of cardiac death?
That's the multi-million-dollar question that we're trying to figure out at this moment. We don't understand it. We know that it's cardiac in origin, but I can't tell you at this moment, is it all rhythm-related and rhythm that a defibrillator potentially would be useful and
Yeah.
aborting sudden cardiac death. There are other arrhythmic tests where defibrillator doesn't work, or is it due to worsening pump failure? We don't understand.
It does make you think back to women that, because I have a lot of fibrosis, but I have a good LVEF.
Yeah,
So I'm like, ew.
yeah.
I get it now.
So,
Thanks.
So what is the standard of care for female carriers right now for cardiac imaging? Is it annually if there's something found? Is it every 3 to 5 if there's no findings? Is that still the standard?
You know, I don't think we've defined the standard, and I think it would depend upon which cardiologist that you are seeing and their assessment of your clinical picture. I mean, all I could tell you is that a normal scan should not be an end point for your care. I think that there should be a period of time in which you go back and ask the questions again, whether that's 2 years, 3 years.
And I think for us, we would say 3 years. And I think, to be honest, if you don't even have dystrophinopathy, you're not a carrier. If you have a first-degree relative with dilated cardiomyopathy, the guidelines say you should be screened every 3 to 5 years. And that's with people who have a much, much lower risk of any cardiac disease happening, right? And dilated cardiomyopathy. So we are at the very base level. What we say is MRI every 3 years based on what we have, or if you have symptoms or other things, we go earlier.
just want to go back to the, as an adult cardiologist who sees a lot of Duchenne young men who are in their 30s and 40s now, and I really struggle to get them into the scanner with the contractures. So that's not a trivial discussion. When I bring that up in clinic, I can see how they roll their eyes back, and their enthusiasm level is, it changes the discussion very, very quickly. And it's been challenging. I mean, I sent some patients for echoes, and literally there are some echo attendings who write me back, please do not send these patients back to us. We don't see anything. It's very, very similar images that Dr. Soslow showed before. And it's tricky. What do we do at this stage? And we really don't want to subject, Duchenne men with to the stress of the cardiac MRI if it doesn't change management. And assessing their left ventricular function over time is critical. And one of the things, even though I can't not assess fibrosis, but I can see if their heart function gets worse by looking at the blood marker ProBNP, which is an established heart failure marker. It tells me whether the heart is stretched, and the more stretched the heart is, that's usually more heart failure, and the ProBNP level goes up. And I can follow that at least serially, and I have several boys who won't be able to be telling me, well, I feel more short of breath when I do certain activities, but when I see over a year, when I do this twice a year, that their ProBNP level goes up, all my alarm bells already go off, and even if the ejection fraction remains relatively normal, that I know that I need to be more aggressive with medications and really intensify what I'm doing. So it's not that if you can't do cardiac MRIs that there's nothing else that you can do. There are a couple of options available, but it gets progressively more difficult.
Brian?
So many families travel to certified Duchenne care centers, also need to keep a team at home who are experienced and understand their son or their loved one's treatment in Duchenne. And because traveling during an emergency to a certified center for more expertise care during an emergency is really inappropriate. But there needs to be some sort of a mechanism so that you get that feedback, because the collection of data, regardless of where it comes from, is important in understanding the broader community in heart failure and heart disease in Duchenne, and how that is initiated, whether it's the cardiologists at the center initiate that with the treating doctors back home, or through the families, so that there is a cross-circulation of those records is vitally important, because I think that we're talking about silos. There's an unintended silo that's occurring because there's data being collected back home that probably could inform the center's where these families travel.
I think that's a really good point. And so as our practice is that anybody who's more than like an hour or two, they need a local cardiologist. They need somebody, especially as they get a little older, they need somebody that can manage acute issues, because I think that's a really important thing. Because like you said, I mean, I'm in Nashville and someone is 3 hours away in Knoxville. They're not going to be sent to me immediately. They're going to go see somebody out there, and they need somebody who's seen them. Our best way around that, so that a lot of those cities and centers really don't have a Duchenne expert, but they have people that we work with all the time for other diseases. So the 5 pediatric cardiologists out there I know personally and have forever because of Duchenne, but also for all the other patients we manage with them. And so I work it out. So they see them every year, and I see them every year, and we are on 6-month intervals. And I send them all my notes, and they send me their notes. And we do the best we can in terms of communication. And it's gotten better with Epic now that most of us, or a ton of us, are on Epic. And I can see what Chet does in Cincinnati if I see a patient that's gone to Cincinnati, or what Linda does at Nationwide, because we're all using Care Everywhere in Epic. But in terms of sharing information, you're exactly right. And that is a systemic issue that we're improving on, but we're nowhere near where we need to be. And that's the entire medical system.
And many of these cardiologists locally never have they have no experience in Duchenne,
Yeah.
but I think the family can help them along the way so that they can become advocates on behalf of their patients. And it's easy to condemn, but it's certainly better to promote.
Oh, and I'd be, just to put a plug in, there are some really bright cardiologists in our outside areas in Tennessee that do a really good job with their Duchenne management. And they come to me after they say, well, I need help with heart failure. And they're already on mineralocorticoids and carvedilol and lisinopril, and they're doing a really good job. So I'm not trying to say they're not up to the task at all. That's why we say they have to see them, because they need someone local who can manage them. So they're great, and it's on us to communicate, and we do the best we can. And I know Chet and Linda do too.
No, I think it's a really important point. I do think that having a cardiologist at home, especially after a certain age, and I don't know what that age is, but it's when there's evidence of cardiac dysfunction becomes really critical. Does a 4-year-old need to duplicate care? Probably not. But there's some amazing cardiologists who really engage back. Always send me an email after they see their patient. This is what I did. Are you okay with this? What would you do with that? And I communicate back and forth. Now, that isn't always the case, and it's because we live in a really busy world, so I'm not throwing a stone, because I'm guilty of that as well. But, just encouraging your home cardiologist, this is my cardiologist at Cincinnati Children's. Would you mind just sending him an email? This is their email address. That makes it easy for me if you give the person the information, or I'll say, what's your cardiologist's email? I'll do that. And if you have that information for me and make it easy for me so I don't have to sort of dig, then it becomes, but if you come to me and say, can you talk to my cardiologist at home about this visit today? And I'll say, well, I have your pediatrician's number. Do you know what your cardiologist's name is? And you're kind of like, Dr. Johnson, I think. She's a girl. I'm like, that makes it really tough for me. So if you can help me out by giving me the information of the person who I need to talk to, that helps.
And I think it's also important for carriers and for adult men. So, people who even want to come see us in Cincinnati, it's sometimes the best they can do is once a year. And they're trying to stay away from the winter months and do all of those things. And what I tell people is you're probably not going to find somebody who's a dystrophinopathy expert. Otherwise, you wouldn't be coming to see me, right, at home. But what you need is someone who's engaged and who fits your family or your own personality and is engaged. And then usually we can work from there. You don't have to have all of the credentials. You don't have to have all of this other stuff. You have someone who's engaged and is willing to have that conversation, and they can be just as effective an advocate. And sometimes it even isn't a cardiologist. Some of our older men, it is primary care providers, it is palliative care doctors, it is all those things, and they become the advocate and the entree, to our system. And then I think the other thing to say is this is where the staff in the clinic is just as important as the doctor, right? So behind you to the left is Beth, our coordinator. Most of our families, when they have an issue, they don't call me, right? They call Beth. And then she can make sure to get to the right place, right? Do you need a pulmonologist? Do you need a cardiologist? Do you need both? Do you need a neurologist, right? I think that is actually really important, because trying to wrangle a doctor sometimes, especially in an acute situation, is challenging. But when you have good staff and somebody that you guys can trust, and often that's a nurse or a nurse practitioner or somebody else, they can get the right people at the right time, and that is not to be underestimated.
No, coordinators are critical to the effectiveness of this operation for sure. Does that answer your question, Brian?
Yeah, it was more of a statement than a question.
Okay. Well, thank you.
That's all right. We're cardiologists. We say, well, I have a question, and then we just go on a rant. And was there a question? Nope, I really just wanted to stand up here and talk.
So Chet, based on your comment that if you have a first-degree relative with cardiomyopathy that you need surveillance, would you recommend that all moms get cardiac surveillance, whether or not they're carriers?
No, I think this really goes, that's where the genetic component is a helpful piece, unless there's some other history that runs in the family. So if we have an identified cause, especially from a genetically driven cardiomyopathy, we'll use that as for what we call waterfall testing, and we go backwards to see.
Okay. All right, we've all got this little computer on our wrist, Andreas. How effective is it in evaluating rhythm, and can it be life protective or life saving, or how much stock do you put in these wearables?
He probably never gets asked that question.
Oh, it's actually more and more patients are asking me in clinic all the time. So,
right.
Yeah, no, it's given that it's so widely available now. Particularly the Apple Watches, the Fitbit, now the newer generations have a similar function to detect atrial fibrillation. Mm-hmm. So from that perspective, it's not medical grade, but they do a relatively decent job at detecting atrial fibrillation. So from that perspective, it's a good device. It's not perfect, but it's good. Similarly, it can detect how fast your heart rate is. Often in boys or in men with Duchenne, we see that they have an elevated resting heart rate, and which may require some attention. From that perspective, it's good too. What these devices are not good is to detect those potentially dangerous, life-threatening arrhythmias. That's what they're not designed for, and that's what they should not be used for.
You know, to me, I think it's interesting because it's almost, if you have the financial means, I would say it's almost a essential piece of equipment to have somebody in the house own one. I mean, the mom can own it and wear it, but, you know, to me, when somebody's saying, you know, I'm having lots of these funny episodes, I mean, if you can give me heart rate data that you have, that can be sort of useful. Yes. And it saves you a trip in. I mean, it can provide, in a world where we sort of want to provide data to your care provider about, you know, my temperature is, right? You know, my resting heart rate is 70, but I think it's racing. Why is that going on? Well, that could be anxiety. I mean, we deal with all these questions all the time. And they are becoming a little bit more cost effective. And not that I want, you know, 5-year-olds wearing Apple Watches with EKG capabilities, but if the mom has it available and can, you know, flip it on the wrist sometimes. I don't know. I think we're exploring that, right? I mean, we're at a point where
we're getting there.
We're exploring it, right?
Yes.
So they're not as effective as a Zio patch or the loop recorder, but it may form a baseline, or maybe helpful for a baseline to need for further evaluation.
They probably drive you crazy, right? I mean, because
they do. Particularly if, you know, patients have they keep it on at night, and then they're asymptomatic, obviously, when they sleep, and the heart rate is 38 beats a minute, and then all alarm bells go off. No, this is normal. Don't worry about it. It's fine. And if patients have, I would always advocate to go for a Zio patch first. It's a medical grade. If they have symptoms, they can push a button so we can correlate the rhythm at that time that they have symptoms, so we can get a symptom-rhythm correlation. It gives us much more information initially. Now, for screening this asymptomatic AFib, that's where these Apple Watches are good for. And you have also to take into account that some patients, their anxiety levels may be very, very high, and If you have a patient who has OCD and is very anxious, an Apple Watch may not be the right thing. If you're doing this all the time and recording EKGs, it may create more anxiety. So,
not that we all don't do this anyway, right?
I have one more. After a boy loses ambulation, what is an acceptable heart rate? I mean, you know, I've heard 100, I've heard 105. You want to keep it at 90. What is the goal there?
it depends on the age of the boy. Obviously, in pediatric, for a child would be very different. It's normal to have a slightly elevated heart rate. For young men, ideally, I would like to see an average heart rate that is less than 90 beats a minute.
90. And then, what is the age-old argument? What's the ACE versus the ARB? I mean, I think it seems like it's half and half. Some kids are on losartan, some carriers are on losartan, some are on lisinopril. Are they equal?
So the studies were done with ACE inhibitors. So it was perindopril, which is similar to lisinopril. So that's clearly where most of the data is in DMD. However, if we extrapolate to other forms of cardiomyopathy, we know that some patients with ACE inhibitors, the most common side effect is that they develop a cough. It's a dry, nagging cough, and can happen about 10 or 15% of all patients who we treat. And obviously, you don't want to take a medication, even if it's prophylactically, or particularly if it's prophylactically, and then you experience side effect. So in that case, the ARBs, or angiotensin receptor blockers like losartan, valsartan, are a really good alternative. We know from other forms of heart failure that they are equal. So it's not like we are sacrificing with respect to therapeutic efficacy if we use an alternative. But usually we would start with lisinopril or perindopril, unless the patient says, no, I have this cough already to start with, and then I might say, well, maybe we go for the losartan or the valsartan. Or the newer ones, this Entresto, that uses one of the valsartans anyway.
Thanks. So several of the exon skipping therapies have warnings about kidney toxicity, and when kids are on ACE inhibitors, we usually recommend that they evaluate kidney function. Do you have any further recommendations for kids that are on both of those therapies, or patients that are on both of those therapies for kidney surveillance? So
we do, whenever anyone's coming into our clinic, we get them every 6 months, so scheduled, and if we're up titrating the aldosterone antagonist, the MRA, and the ACE inhibitor, then we'll usually get one in between. Where you have to watch out for is a couple of things. One, if, especially in our older men, their blood pressure is an issue, and that can be a problem from a kidney perspective for what we call the kidney perfusion pressure, which is the difference between your vein pressure and your blood pressure. If your vein pressure is the same, but your blood pressure comes way down, the driving force of blood that goes to that kidney goes down, and that can cause some issues. And so whenever you add a different medication on board, you just, especially in more advanced disease, you need to be aware of it. And that also especially applies to if your right ventricle isn't working. Even though we've mostly been talking about the left ventricle, actually the better predictor from a heart failure perspective is actually what your right ventricle is doing and what your pressures are on your vein about how your kidneys interact. So I think it does require monitoring. And the other thing that is important is that potassium. So because when you're on an aldosterone or a eplerenone and an ACE or an ARB, it turns out your risk for having an elevated potassium is there. And where we have seen it, and we've seen it in about 5 to 7 men, is when somebody adds another medication on board. So you add on, what we call polypharmacy, multiple different medications that can raise your potassium. And we have had at least one man who had to be admitted to the hospital because his potassium was at a level that was potentially life-threatening. Now, he did not have an issue, which is good, but it can happen, and it can happen especially when you're on multiple medications. The one that I would draw attention to that most people don't think about, and because it's usually done from an internist or a pediatrician perspective, is antibiotics. And the one that happened for that young man was Bactrim, which is one that's used for potentially for skin infections. Sometimes it's used for upper respiratory and ear-related infections. It doesn't necessarily affect the kidney function, but it can cause potassium to go up. And that's what happened is they weren't thinking about it from that perspective. And for a lot of our men, they're on, dear God, 20 meds, right? Keeping track of all of them and the interactions is sometimes a real challenge. So while it's a rare issue, it can be an issue, and especially if those things happen, it can be life-threatening. So we have to watch for it.
Okay. Any reason to, I mean, is 10 the magical age, or is there a reason to or not to start cardioprotective meds before that?
Oh my God, that is the question that we deal with like every day,
well,
right?
That's why I wanted to ask it again.
I know, it's like...
Are we done yet?
I know,
you stay there.
Okay, so to know the answer to that question, like many years ago, we sort of sat down and we said, we need to answer this question, right? When should we start ACE inhibitors, or when should we start cardioprotective meds? And we priced the trial out. And this was maybe, like 15 years ago or whatever. And it was going to be like millions of dollars, right? Because you're going to have to do it in young children, and you're going to have to follow them for years, and you're going to have to put all the regulatory things in there. And we just thought, it's just not a question that is critical to know the answer to, right? So I don't think we're ever going to officially know the answer. Now, if you intellectually think about it, you can tell that I've given this response a million times. If you really want to intellectually know it, I can think of at diagnosis why you should start it. And if you really talk to basic scientists who are really smart people, right, they really think that you probably should, because I think there's a lot of intellectual disconnect. Because the only reason why we say there's fibrosis is we're looking at it on MRI, but if we were actually able to take a piece of your heart and look at it under a microscope, we're going to see changes early on. And we see EKG changes sometimes in newborns with Duchenne, like LVH or other types of things, showing that the myocardium probably is impacted at a very early age. So if the myocardium is impacted at an early age and we're putting this on prophylactically, let's start it at a very early age. Now, the alternative argument, like Chet just talked about, is that every medication has side effects, right? And do you really need to be on it early? And are we going to really change the outcome by starting it early? If your window is already clean and we put more Windex on it, are we making the window even cleaner? So I think that the answer is up in the air. I would start it before the age of 10 in my child if I were in your chair. At what age would I start it? I'm not quite sure. I think it's a hard one.
Boy, be careful.
I don't know. We'll survey the crowd. I don't know what.
And I think that we're definitely not in agreement as a group on this. I'd started at 8, essentially, for that reason. Because I was like, if it was my kid, I would want to be on this earlier. And I don't see a lot of downside. I really don't see many side effects at all in those 8-year-olds that I started on. And I'm doing a low dose. And so they tolerate it just fine. But it's always a conversation between me and the child and the parent. And what do you want from your care? How aggressive do you want to be? And there are plenty of patients who are like, we're not ready. We don't want to start a medicine. Mm-hmm. And there are patients who are 6 and 7 where they're like, can we start a medicine? And so it really is, it depends on what the family wants and just going through the data we have, which, as Linda said, is like nothing.
It's not a dystrophin-specific therapy. I think that's the thing to appreciate, the fact that we're not impacting dystrophin. Yeah. It's a heart failure medicine. It's a blood pressure medicine. If you're on steroids and your child is gaining a lot of weight and, steroids cause fluid retention, you can argue that your blood pressure is higher than it would be if you weren't on the medicine. And so maybe lowering the blood pressure isn't such a bad thing, even if you're lowering it just a little bit with a low-dose ACE inhibitor.
And I think the other thing to keep in mind is, so 10 was picked out of thin air. When you look at MRI in centers that scan beginning at 8, so our initial data showed that about 10 to 15% of boys would have LGE before age 10. So if you're not getting MRI, I think there's also a more pressing reason to do it. And so that's what I'd say. In terms of if we're going to start it, I say, hey, I don't have data. Let's work on it, and then let's monitor from that perspective. And then also when I talk tomorrow, we're going to talk about dose optimization and other stuff. If I am starting it that early, it is the one time where I don't try and up-titrate because of the potential for side effects. And where this really matters is knowing the strength of your boy. The one thing that the two things I worry about is 1, the kidney and the electrolytes, and 2, making sure I don't push that dose to the point where you feel dizzy. right? So when any of us stands up really quickly, you know how you get that little orthostatic symptoms and sometimes you feel a little woozy? These medications can sometimes, especially in young kids, and this has been documented in a variety of cardiomyopathies, right, can cause that. For most of the kids that I take care of with congenital heart disease or other types of cardiomyopathy, if they feel woozy and fall over, it's sometimes a big deal, but not really. This can be life-altering for a boy, right? You guys know that. If you have a fall and you have a fracture, that's a big deal. So you got to have that whole picture. This is this is like everything else that you hear here. This is, you got to have that whole picture. And if you're doing stuff with little data, which I do, right? There are some families, and I say, hey, that's reasonable, but you have to keep that whole picture in mind, because I don't want those side effects, and a fall for me is life-altering.
So one of the other questions was, do we know if there's any cardioprotection from CoQ10?
I'm going to say, I don't know.
I'm going to say, so I'll be more definitive. Okay. No. We just don't, there's no, in any cardiomyopathy, it has just not borne itself out. And while CoQ10 is not as bad as some of the other vitamins and supplements that use, some of those vitamins and supplements have real drug interaction problems, and some of them also have real long-term risks. So we think about it from an ACE perspective. We just spent all this time talking about it. It turns out over-the-counter and vitamins, especially ones that are not regulated, can carry an appreciable risk.
You know, and then there are some basic scientists and some adult cardiologists like Beth McNally who think that eplerenone should be started earlier, right? Mm-hmm. Because of the antifibrotic capabilities and its similarities to some of the steroids, right? And so they've wanted to do a trial of using eplerenone so you could even. That could be investigated as well either.
So that's why pulling all these centers' data together with all this patient experience and all this natural progression and difference in therapies and clinical outcomes is so critically important.
I think the most important word in this whole thing is harmonization.
So can you define harmonization? What's the difference between harmonization and standardization?
Well, so standardization, if I can make you do what I want you to do, that's standardization. We can't do that. Right. Harmonization is saying, here's what we're trying to go by. Let's stick to that as much as possible, because I can't dictate to you. If you're in a clinical trial, I can dictate to you what you're going to do. But outside of a clinical trial, we can't do that. So we come up with, here's what we're all trying to do to minimize that. Because again, if you're going to try and say, I'm going to start eplerenone at age 8, how am I going to be able to tell the difference if I start my lisinopril at 10, John starts it at 8, somebody else throws a beta blocker in? It becomes a really messy thing to try and answer that question. It's why you guys all know, right? If you get into a clinical trial, or when we're coming and we're saying, hey, we're going to titrate this, and you say, no, can't do it because I might be doing the next gene therapy trial, it doesn't work. And that same thing applies from a cardiac perspective. If we minimize the variation, we say, hey, this is what we think is the best thing, it gives us a better chance to be able to answer that question. The other thing that it does is it allows the trial, as you heard from John, to be smarter. You get a better answer from a smaller group if you know a little bit more about that. And importantly, right, for this community, you minimize the amount of people who are not getting therapy, right? Because if you can power a study better, we can answer a question more effectively and minimize the number of boys and men who are not given a therapy as part of a trial. And this is going to be especially important from a cardiac perspective, because our trials are probably going to take longer. We're probably going to be having to follow them a little bit longer to be able to answer these questions based on what we know right now.
And I think that your comments are so important, but for those of you who've been in the room for 2 decades, or those who've been in the rooms for a decade, and even for those of you who are brand new to this room, these conversations were not had before, right? Mm-hmm. There has not been a critical mass of cardiologists in this country, adult cardiologists, electrophysiologists. I mean, like, so lucky to find an electrophysiologist who's willing to engage in this disease. I mean, it's so critical because we can't change the way we're thinking about things. We can't have Brian's question be answered appropriately with regards to when you have to have a local cardiologist, getting that information out to those local cardiologists without the cardiac community engaged in this disease. And historically, for a wide variety of reasons, they haven't been, but they are now. And so I think that if you get on your plane on Sunday and you learn one thing at this meeting, I think it's that cardiac care has reached a tipping point. And I do celebrate that. And I will attribute that to Parent Project Muscular Dystrophy and their constant push to change that outcome, to fund clinical trials, to fund cardiologists, to call cardiologists up and say, can you help us? And we say no, and they say yes, please, and then they call us up again. I mean, to really beg for it. And so I think you really should be proud of this organization. I am proud of this organization. And because I think in this area, and in many other areas, but in this area in particular, that push has taken 2 decades, but I think that push has finally reached change.
Yep, I can't agree more. And like I said, in the last 22 years, 27 years, it's just, we've come leaps and bounds beyond where we ever could have imagined this would have come, so.
Well, and I think the one last thing, you know, some of those figures that you saw from Andreas about long-term survival, right? So they were splitting up men into before, you know, 1970 when they were born and after 1990. We are publishing what we call seminal information that took us 30 years to answer that question. That's just not okay. 30 years.
Wow. Well, with that.
Well, no, that's not depressing. That it goes to Linda's point. If everyone's in a silo and people aren't working together, right, that's what it takes to answer that question. Because you need to have enough numbers at an individual center to be able to do that, and that takes time. But people were there.
Right.
We weren't sharing the data.
Right.
We're not sharing the data. And as much as this disease is a skeletal muscle disease, and I really don't want to take away from that because I think that's really critical. This is a cardiomyopathy. This is a heart muscle disease. And the heart muscle disease is a big problem. Yep. And if we don't find solutions to the heart muscle disease, if we don't demand that industry put cardiac markers and endpoints in their clinical trials, we are not going to have the answers that we need to inform you about whether these treatments and therapies should be used.
Well, I can't thank all of you enough for being here and for doing what you're doing and for contributing to this community and the lives and well-being of all of our families and patients. So thank you, thank you, thank you. This has been fabulous. Thanks.